Dear viewers, this is part 2 of the two-part series on the anemias in the Medicine for Anyone in the YouTube channel. Iron absorption in the duodenum is regulated by hepcidin, a peptide synthesized and released from the liver in response to increases in intrahepatic iron levels. Hepcidin inhibits iron transfer from the intestine to plasma. As a result, as hepcidin levels rise, iron becomes trapped within duodenal cells in the form of mucosal ferritin and is lost as these cells slough. Thus, when the body is replete with iron, high hepcidin levels inhibit its absorption into the blood. Conversely, with low body stores of iron, hepcidin levels fall, facilitating iron absorption. Dear listeners, by the way, this educational video is made possible by Prescribon, the makers of e-prescription software for digital prescriptions available freely for doctors on the website www.prescribon.com. Doctors who are interested in this e-prescription can freely avail of its vast collection of more than 100,000 e-prescriptions. Etiology of iron deficiency anemia. Iron deficiency can result from 1. Dietary lack, 2. Impaired absorption, increased requirement, or chronic blood loss. To maintain a normal iron balance, about 1 milligram of iron must be absorbed from the diet every day. Because only 10 to 15% of ingested iron is absorbed, the daily iron requirement is 7 to 10 mg for adult men and 7 to 20 mg for adult women. Average daily dietary intake of iron is about 15 to 20 mg. Most men ingest more than adequate iron, whereas many women consume marginal amounts of iron. The bioavailability of dietary iron is as important as the overall content. Dietary lack is rare in high-income countries, where, on average, about two-thirds of the dietary iron is in the form of heme, mainly in meat. The situation is different in low-income countries, where food is less abundant and most dietary iron is found in plants in the poorly absorbable inorganic form. Dietary iron inadequacy occurs even in high-income societies in the following groups. Infants who are at high risk due to the very small amounts of iron in milk. Human breast milk provides only about 0.3 mg per liter of iron. Cow's milk contains about twice as much iron, but its bioavailability is poor. The impoverished, who can have suboptimal diets for socioeconomic reasons at any age. Older adults, who often have restricted diets with little meat because of limited income or poor dentition. Teenagers who subsist on junk food. Increased requirement is an important cause of iron deficiency in growing infants, children, and adolescents, as well as premenopausal women, particularly during pregnancy. Chronic blood loss is the most common cause of iron deficiency in high-income societies. External hemorrhage or bleeding into the gastrointestinal, urinary, or genital tracts depletes iron reserves. Iron deficiency in adult men and post-menopausal women in high-income countries must be attributed to gastrointestinal blood loss until proven otherwise. Clinical features. The dominating signs and symptoms frequently relate to the underlying cause. For example, gastrointestinal or gynecologic disease, malnutrition, pregnancy, or malabsorption. Anemia of chronic inflammation. Impaired red cell production associated with chronic diseases that produce systemic inflammation is a common cause of anemia. This form of anemia stems from a reduction in the proliferation of erythroid progenitors and impaired iron utilization. The chronic illnesses associated with this form of anemia can be grouped into three categories: chronic microbial infections such as osteomyelitis, bacterial endocarditis, and lung abscess; chronic immune disorders such as rheumatoid arthritis and inflammatory bowel disease; neoplasms such as carcinomas of the lung and breast, and Hodgkin's lymphoma; aplastic anemia due to bone marrow dysfunction. Bone marrow aplasia means lack of functioning bone marrow. For example, exposure to high dose radiation or chemotherapy for cancer treatment can damage stem cells of the bone marrow, followed in a few weeks by anemia. Likewise, high doses of certain toxic chemicals such as insecticides or benzene in gasoline may have the same effect. In autoimmune disorders such as lupus erythematosus, the immune system begins attacking healthy cells such as bone marrow stem cells, which may lead to aplastic anemia. In about half of aplastic anemia cases, the cause is unknown, a condition called idiopathic aplastic anemia. People with severe aplastic anemia usually die unless they are treated with blood transfusions, which can temporarily increase the numbers of RBCs, or by bone marrow transplantation. Megaloblastic anemia. See discussion of vitamin B12, folic acid, and the intrinsic factor from the stomach mucosa in red blood cells in Medicine for Anyone YouTube channel. Loss of any one of these can lead to slow reproduction of erythroplasts in the bone marrow. As a result, the RBCs grow too large with odd shapes and are called megaloblasts. Thus, atrophy of the stomach mucosa as occurs in pernicious anemia, or loss of the entire stomach after surgical total gastrectomy can lead to megaloblastic anemia. Also, megaloblastic anemia often develops in patients who have intestinal sprue, in which folic acid, vitamin B12, and other vitamin B compounds are poorly absorbed. Because the erythroblasts in these states cannot proliferate rapidly enough to form normal numbers of RBCs, the RBCs that are formed are mostly oversized, have bizarre shapes, and have fragile membranes. These cells rupture easily, leaving the person in dire need of an adequate number of RBCs. Hemolytic anemia. Different abnormalities of the RBCs, many of which are acquired through heredity, make the cells fragile, so they rupture easily as they go through the capillaries, especially through the spleen. Even though the number of RBCs formed may be normal or even much greater than normal in some hemolytic diseases, the lifespan of the fragile RBC is so short that the cells are destroyed faster than they can be formed, and serious anemia results. In hereditary spherocytosis, the RBCs are very small and spherical rather than being biconcave discs. These cells cannot withstand compression forces because they do not have the normal loose bag-like cell membrane structure of the biconcave discs. On passing through the splenic pulp and some other tight vascular beds, they are easily ruptured by even slight compression. Sickle cell anemia. In sickle cell anemia, which is present in 0.3 to 1% of West African and American blacks, the cells have an abnormal type of hemoglobin called hemoglobin S, containing faulty beta chains in the hemoglobin molecule. as explained in the topic of red blood cell in medicine for anyone in the YouTube channel. When this hemoglobin is exposed to low concentrations of oxygen, it precipitates into long crystals inside the RBCs. These crystals elongate the cell and give it the appearance of a sickle rather than a biconcave disc. The precipitated hemoglobin also damages the cell membrane, so the cell becomes highly fragile, leading to serious anemia. Such patients frequently experience a vicious circle of events called a sickle cell crisis, in which low oxygen tension in the tissues cause sickling, which leads to ruptured RBCs, which causes a further decrease in oxygen tension and still more sickling and RBC destruction. Once the process starts, it progresses rapidly, eventuating in a serious decrease in RBCs within a few hours and in some cases death. In erythroblastosis fetalis, Rh positive RBCs in the fetus are attacked by antibodies from an Rh negative mother. These antibodies make the Rh positive cells fragile, leading to rapid rupture and causing the child to be born with a serious case of anemia. The extremely rapid formation of new RBCs to make up for the destroyed cells in erythroblastosis fetalis causes a large number of early blast forms of RBCs to be released from the bone marrow into the blood. Polycythemia, secondary polycythemia. Whenever the tissues become hypoxic because of too little oxygen in the breathed air, such as at high altitudes, or because of failure of oxygen delivery to the tissues, such as cardiac failure, the blood forming organs automatically produce large quantities of extra RBCs. This condition is called secondary polycythemia, and the RBC count commonly rises to 6 to 7 million per cubic millimeter, about 30% above normal. A common type of secondary polycythemia called physiological polycythemia occurs in those who live at altitudes of 14,000 to 17,000 feet, where the atmospheric oxygen is very low. The blood count is generally 6 to 7 million per cubic millimeter, which allows these people to perform reasonably high levels of continuous work, even in a rarefied atmosphere. Polycythemia vera, erythremia, is the other name. In addition to physiological polycythemia, a pathological condition known as polycythemia vera exists, in which the RBC count may be 7 to 8 million per cubic millimeter, and the hematocrit may be 60% to 70% instead of the normal 40 to 45%. Polycythemia vera is caused by a genetic aberration in the hemocytoblastic cells that produce the blood cells. The blast cells no longer stop producing RBCs when too many cells are already present. It usually causes excess production of white blood cells and platelets as well. So, dear viewers, this is the end of part 2 of the two-part series on the anemias in the Medicine for Anyone YouTube channel. Thank you for watching the video.